It's a full agenda tonight. We're going to be doing a fairly interactive session with a number of very esteemed panellists who are with us here tonight. And we've also got a couple of guest speaking slots. We're going to keep those to a relatively constrained 10 minutes per speaking slot, and we've allocated the bulk of tonight for interaction with the panellists, given the importance of the topic. We also, at the conclusion of the evening, just to explain how this will operate, have some more mingling and time for some drinks and final networking after the event tonight.
Good evening, everyone. It's a pleasure to be here today and share with you a little bit about IBM's perspective on what patients want. I'm actually going to cover 3 quick topics. So I've got 10 minutes, so you can imagine it's going to be pretty quick. One is patients' trust in the system. And for many of you, you may not know, I'm from Singapore, and we've had an electronic health record for the last 7 years. I'm actually going to share a little bit about our experience with that there, and also talk a little bit about population health management as well, which really is about analytics and patient engagement. And you know, again, this topic of my health record, it's about the clinical view, the patient view, so I'm going to zone in a little bit more on the patient view. So some of you may have heard this. This is big news in Singapore. There was a big cyber attack. 1.5 million patient records were compromised, where they stole our national ID, a lot of the demographic information, etc. And this is in one of the Singapore healthcare clusters, so it's a group of hospitals. Now, luckily, it was the EMR, not the electronic health record, but obviously that scared a lot of citizens of Singapore. So when you think about cybersecurity, it's actually very, very complex in a healthcare setting, because as you can imagine, it's not just about data, it's not just about applications. We're talking about remote monitoring, medical devices in a hospital, right? And they actually say that right now ransomware is all about pay to get your data back. Well, they're predicting that it's going to be in the future pay to get your life back, because some of these medical devices are life supporting and people can hack into them. And so really, when we think about cybersecurity, it's a total ecosystem approach, right? And I like the way IBM talks about this, because I can relate, being in healthcare. It's like the immune system, right? Our own immune system protects our bodies by knowing where there's a foreign object, right? And the whole idea is, how do you detect something early and know that there's a threat? How do you protect your organization, prevent things from happening, and respond? And so for us, actually, AI plays a very big role in this. And what's scary is the hackers actually use open source AI systems to hack. So you need better AI systems to be able to go back and protect yourself as well. So for us, the whole ecosystem is very important. And especially, as I said, when you look at an electronic health record in Singapore's context even, now they're very focused on, well, it's not just about the hospitals, it's about the full ecosystem, mobility, the devices, and how do you put in place an overall plan. And so, for example, like in NHS in England, they're working with us over 3 years to basically put in place almost like a full command and control setup to manage cyber attacks for their whole healthcare system, right, as well. And I won't go into a lot of details, I don't have a lot of time, but it really is about, as I said, trying to defend, protect yourself up front, because it is like your immune system. If you have a solid immune system, you can actually prevent a lot of these things. And I can tell you, 3 months ago, Singapore had no idea they were vulnerable, right? If you asked them, they would have felt very secure. What I'd like to switch to is talk a little bit about population health management, because when you have an electronic health record, it's very powerful. You can start looking at your entire population. And we all know that typically 20% of the population of a country accounts for 80% of the healthcare costs. And so what about the 80% that are healthy today, right? Nobody's really looking at them. And with the power of analytics, you can start risk stratifying these 80% and actually identify who are going to be the next people that are going to get sick. And secondly, how do you reach out to them in a way that's personalized for them, right? If I'm a very healthy young 20-year-old that runs every day, I don't need outreach to me telling me a lot of information. I probably need maybe every 6 months an email saying to check up with your doctor, etc. But if I'm very sick, I probably need a lot of high touch. And this personalization is actually key. So what do patients want? They want you to know them. What did they want? And this is experience from Singapore too. What's my history? What are my preferences? this is interesting because, for example, I'm a working mom. I have 2 kids. If you call me in the middle of the week, I probably won't respond if you tell me to go in for my mammogram. But if you text me on a Saturday morning, I'll probably respond. So actually understanding what works for patients, what's the best way to engage them, it's almost like CRM, but in a healthcare perspective, right? Because you're understanding their preferences. Engage them, right? Be relevant, send them relevant information, and empower me. And again, this is where AI comes into play, because AI actually helps you personalize content to the patients that you're reaching out to. So it's all about proactive, personalized, targeted patient engagement, right? And this iceberg is interesting because really, again, it's talking about today, everyone's aware of those people that are sick, very sick, the 20% that are chronically ill because they keep going back to the hospital. But what about the 80% below the line? As I said before, it's all about wellness and prevention. And what's interesting, if you look at the statistics, 67% of patients who were catastrophic this year were not last year. So if you don't address that 80% outside, they're going to keep increasing on the right. And again, what can you do? Well, with the electronic health record, you can start identifying care gaps. So if I'm an uncontrolled diabetic that has not had my foot screen done in the last 6 months, I'm vulnerable to losing my foot. So if this system, now that you've got this electronic health record, I have my history, you can use tools that automatically go through this data, identify a care gap, and will outreach to those patients to pull them in. And the exciting thing with this is that there's huge results in terms of prevention, right? These are statistics of projects that we've done in the US where you can actually increase the number of patient visits for non-adherent diabetics. You can actually increase the number of mammograms that you get, preventative colonoscopies, right? So basically the ability to identify care gaps. Why? Because you first of all have identified a care gap specific to an individual, but you've also reached out to them in a way that's going to make them actually more responsive, right? And I think this is exciting because, again, this is really about how do you engage patients, how do you change their behavior? And in healthcare, we all know behavioral change is probably one of the toughest areas to focus on, especially from an IT perspective, right? Everyone responds very differently, but the more you can personalize patient engagement, the better it will be. Now, I just wanted to end off with one last slide. This is my health record in Singapore. There's nothing very personal on here other than it's got my kids' immunization records on there, which actually is very helpful to me because I have no idea what I've immunized them for. But what Singapore started with is they started with the electronic health record, and it was meant for just doctors. And we went opt-out immediately, so we didn't even know the difference, right? We were always opt-out. So everyone's in it as long as you hit a public healthcare system. And what I find very helpful about it personally is that my father is a diabetic, and he's got multiple comorbidities. He's got hypertension, he's got kidney issue, the usual elderly issues. And I can actually go on as his caregiver, and I actually have full access. Before, I'd have to literally carry files as I went between hospitals. And that was very painful for me because if I missed something or I missed a medication, I felt like it could have impacted his health. And the other part that's actually really great is that this actually is starting to go into things like financial counseling for citizens as well, because it has my electronic health record information. And by the way, as a patient, I don't see everything because I think patients don't need to see every single thing in there. That's kind of been the lesson from Singapore, just the key elements that are some of the vitals and some of the tests you've done, et cetera. But it also tells me if I'm going to a hospital, am I eligible? What am I eligible for from a government perspective? So again, I think what Singapore's tried to do is really tailor this to ensure that it's something that a patient would find useful. The clinicians over time have found it very helpful, especially in places like ED, where if someone's coming in unconscious and there's a history that they're allergic to penicillin, they don't have to call the family member, it's already in the record, right? And so again, I guess my final closing remarks, I think that's 10 minutes, isn't it? Am I okay? Yeah, so is really just, I think as we move forward with this whole concept of population health management, really, this is really where things are moving, right? And even as I said, the Singapore government's next big focus with their health record is how do you take that data, risk stratify your population, reach out to the population in a very personalized way, and actually they're injecting AI wherever they can, right? To basically make that experience much more user-friendly, right? And getting care anywhere at any time, that's pretty well what millennials expect anyway. But really having this information at your fingertips is something that I think is actually what's made it more, people are more willing to adopt a system like this. And I guess my very last point, and as I said, I started with this, people need to trust the system, right? To be honest, no one has had any issues in Singapore with electronic health records. People have trusted the government, there's been no issue, but with this cyber breach, there's a lot of concern all of a sudden, right? Because people are wondering, is my data safe? The reality is that, obviously they're very, very focused now, and IBM is actually working with them too to see how we can help them to create this very solid ecosystem of protection. And as I said, kind of focus on building this immune system for the country so that it is kind of impenetrable, right? And you'll always need to reach out globally, and that's where having a global intelligence, facility like we have this X-Force Command Center, kind of tracking globally what's happening from a cyber attack perspective actually helps countries, because you're not going to be the last to know. There's actually going to be tools out there that help you identify these threats very early. So with that, I'd like to thank you for your time, and I'll hand over to you, Paul. Thanks.
I thought I'd start with a graphic that really just takes us through some of the reasons why we are doing this. So what are the outcomes? What are the problems that the My Health Record and other digital health infrastructure is trying to solve for Australia? And this really just paints a nice snapshot from pre-birth all the way through to aged care. And if you look along the top, that's where we're at today. So, a healthy pregnancy usually includes 15 to 20 separate encounters with healthcare services. How do we start to join all of those encounters together for not only the clinician, but also for the mother and for the baby? 40% death rates for remote Australians are 40% higher for coronary heart disease. How can we start to provide better care services through digital infrastructure for those people? And digital tools obviously make it easy to access those services remotely. You've probably seen this statistic before, that 223,000 people are admitted to hospital due to adverse drug events every single year. And having medicines information available via systems like My Health Record, as well as very sophisticated EMM systems within hospitals themselves, helps to really reduce that risk. In fact, I was just talking to someone earlier and letting people know that we've now got almost 70% of community pharmacies registered for the My Health Record system, and they're rapidly connecting all of those pharmacies up to send dispensed medications up, which will be a huge boon for hospitals and other people who want to see that information to know what's actually being dispensed for consumers. And likewise, 14% of pathology tests are ordered due to lack of access to patient history. And we are now starting to connect both public and private pathology and DI practices to the My Health Record system, and we're starting to see quite large numbers of pathology reports and DI reports finding their way into the system. So there's some of the reasons why we've got a digital infrastructure in place in a My Health Record to help with these sorts of problems that we've currently got. Very similar to the problems I think that was articulated by the Singapore My Health Record and what it was trying to solve. So My Health Record is basically a secure online summary of your health information. So just like you were saying in Singapore, it's not absolutely everything. They're key pieces of information. But in Australia, you choose who it's shared with, you choose who can access it, and you choose what's in it. So it's not a government control system, it's not a clinical control system, it's a patient control system, which is at the core of the My Health Record system. So what sort of information, for those that don't know, does the My Health Record system hold? So if you go to your general practitioner, they can upload what's called a shared health summary, which is a snapshot of information that's contained in their local systems, your adverse reactions or allergies, your current medications, your problems, your diagnoses. Hospitals around Australia, both public and private, are by and large uploading discharge summaries for patients as they leave the hospital. Path and DI I spoke about just earlier, both public pathology reports and private pathology reports, and similarly for diagnostic imaging practices, they're also uploading reports into the My Health Record system. From pharmacy, community pharmacy, I spoke about earlier, and that's dispense records from pharmacy, as well as the prescription record from the GP or from the hospital if they're sending those up. So you can see that they're the sort of key elements of the record and the sorts of information that you as a consumer can ask to have uploaded and that other providers in the network can see. We've sort of spoken about some of those key My Health Record benefits, but I thought it was just worthwhile going over the key ones. So we're looking to avoid adverse drug events through the availability of medicines information and allergy information in the system. Improve systems through secondary use of data, and I can touch on that a little bit later. Enhanced patient self-management, so it is a patient-centric system, and patients can, as consumers, can see all of your own health information through the consumer portal. So it's about empowering patients to be able to have a look at what's being said about them, what's being captured about them, and being able to better control their health outcomes, which leads to improvements in patient outcomes. For clinicians particularly, reduced time gathering information. We've had lots and lots of clinicians tell us that they've found useful information in the My Health Record system that has saved them a lot of time with a patient in front of them instead of having to ring and chase information that they needed to continue the care. And as I said earlier, particularly with pathology and DI, avoid duplication of services, which is a benefit to the consumer as well as to the clinician who doesn't have to reorder that test. So this is really important, and I wanted to stress this tonight in light of the discussions that are going on, the public discussions that are going on in the community at the moment about consumer control of the My Health Record system. So it is important to realise that individuals do control who can access their My Health Record system. Consumers can choose to restrict access to specific documents or in fact to the whole record. They can add what we call a record access code to it, so that anytime anyone wants to look, you would have to give them a PIN number to put in before they can open that record. Consumers can subscribe to an SMS or email service that will alert them anytime anything is added to the record or anyone views that record. Also, in an emergency, a clinician can exercise a break glass facility, but instances of that are monitored and logged. And all instances of access to My Health Record are recorded, and you as a consumer can see that full access log whenever you go into your consumer page, so it's there for you to see. Secondary use of data. So people with a My Health Record, and this is a really important point, will be able to choose not to have their data used for secondary use purposes. So you can choose to have a My Health Record, but also choose within that not to have that data used for secondary use. So it's not all or nothing, and that's the design that has been developed through consultation with the community by the Department of Health. We're also working with Aboriginal and Torres Strait Islander People's Advisory Panel to ensure from a cultural safety and appropriateness perspective that secondary use data is managed appropriately where they choose to do so. That withdraw participation function will be available in the My Health Record system from now. It's actually in there. But the release of data for secondary purposes is expected to commence from 2020. So we're a few years off that right now. So where are we up to? So Australia will be the first country of its size to have provided citizens with a summary of their health information, and that's accessible not only through your desktop, but also on your mobile phone. More than 5 million Australians already have a My Health Record. In fact, it's either just nudging or just over 6 million. So although we're in the opt-out period, every week people are registering and choosing to opt in to have a record created for them ahead of time. And by the end of 2018, every Australian will have a My Health Record unless they choose not to. So how were we communicating and what are the opt-out timings? So you're probably all familiar with this. We had a pre-opt-out information packs which were delivered to all our supporting healthcare services, GPs, ARCHOs, pharmacies and hospitals. The opt-out period commenced, I think it was 15th of July. It's now been extended by 1 extra month, so the opt-out period formally concludes on the 15th of November this year. We'll then have a 30-day reconciliation period prior to the creation of those records, so 30 days beyond 15 of November. That's to allow for anyone who is choosing not to have a record on a paper form. So there is a paper process that needs to be accounted for and all of that reconciled. After which time, if you haven't opted out, a record will be created for you. You may have seen some of the branding on bus stops, on advertising billboards. It's your health record in your hands, and that's the slogan for the campaign that we're running across the country right at the moment. We've also created a brand new website and social channels that support all different types of audience needs. So there's a YouTube channel, there's Facebook, there's Twitter, there's all sorts of sites you can go to not only learn about the benefits of the My Health Record system, but to do practical things, to learn how to do practical things like set access controls, like manage your account, all those sorts of things. And they're actually very, very good. And I'd encourage anyone who wants to know more about it to go to some of these sites and have a look at it if you're unsure about how some of those things work. Communicating the message is obviously extremely important. We need to reach 100% of Australians, obviously, to let them know that this is happening. It's been a double-edged sword with all the media that's happening at the moment. On the one hand, it's not great. We've had to manage lots and lots of inquiries, but on the other hand, there's probably very few Australians who now haven't heard about the My Health Record. But we're educating healthcare providers to ensure that all healthcare providers know about the My Health Record, know about opt-out and why we're doing it, and how that would all work. We're also communicating through health networks like PHNs and communicating outside of health networks. You can see up here that we have all the different channels for reaching different communities through health channels, community channels, advocacy groups, digital, online, advertising and news. And you'll see My Health Record this year is being promoted really strongly across all those channels right across the country. We have 3 main opt-out channels: online, via phone through our call centre, and by completing a form and returning it via mail to us, the system operator. So what I thought I'd do just to conclude is just to play you a nice short video of people who are actually using My Health Record and what they think of it. This was done, I think, just the other week in Busselton.
Busselton is a coastal town. It's about 250 kilometres from Perth. Friendly's Pharmacy Busselton is a community pharmacy. We look after the aged care facilities down here in Busselton, and we provide healthcare services to all the people in Busselton. We started using My Health Record as soon as it became available to us.
My Health Record is going to allow us to access our records much more easily. You know, we've moved a few times, but as a result, we've had different medical practitioners. So the fact that the records are readily accessible is good. So we're very happy with that.
Previously, we would have to contact all the health professionals independently and try and gain access to that information. With My Health Record now, the information is together and we have easy access to medication. We could see the efficiencies that were there, and also I think it gives the pharmacy the full picture of what's going on with patients' health. The benefit to the community for having a My Health Record is that information is together in one place and nothing will get missed.
Well, I think the good part about My Health Record is that all your records are in the one place. Only health professional can access them, particularly in an emergency. Should I be over east, live in Perth, then the doctor over there, or the hospital, or the pharmacist over there can assist me.
Before My Health Record, when a patient was discharged from hospital, it could be very confusing for them. All the medications have changed. They don't look like the medications that were taken before they went into hospital. And from a pharmacy perspective, it was very difficult to bring it all together and try and make it clear for them as to what they needed to do and what they needed to take. Our pharmacists have been trained in how to handle this kind of information with sensitivity and privacy.
My health record helps us work a bit more efficiently in the dispensary because we're able to access the patient's records online, and then we're able to help them a bit more effectively, and it makes the whole process a lot quicker.
Pharmacy has always played an important role in the quality use of medicine. My health record allows pharmacists to do their job to the best of their ability.
So, what I'll do now is I'll introduce the panellists in turn. We're not going to do long introductions tonight, and I'll just get them to come up and take a seat. So, would you please join me in welcoming? We'll do the welcomes to everyone when they get seated, but if Neville, you could first come up, please. Neville Boyd's the Chief Digital Health Officer for DHHS Victoria. Louise Shaper, who is the CEO of the Health Informatics Society Australia, HISA, that we're part of here today. I'd like to introduce as well Tony Abenante. Tony wears two hats. Tony is actually the President of the Victorian Council for HISA, and Tony is also the Director for the Strategy and Advisory Group within the digital health team that Neville runs in Victoria. And also I'd like to welcome Tanya Mortensen, and Tanya is the e-health design authority within Tony's area, and Tanya has been most particularly involved in the My Health Record expansion project. So I think you'll agree we've got a pretty expert group here tonight, capable of answering, I hope, most questions. Would you join me in welcoming the panel? So, what we'll do to start with, just before we ask questions, and we've got a mic there, and I'm not sure if we've got two roving mics or not. We might not actually, so we might just have to be nimble with the one mic or get people to speak loudly. We're going to ask three quick polls. I'm not sure I've got the first poll. Yes, the first poll. Now, we've got a mixed audience, and we invited people from just different walks of life here tonight. For the clinicians and health service providers in the room, if you could respond to this poll question, please. Damien, if you're able to activate that. Given My Health Record is now opt-out, do you think it will make a substantial impact to you in the next 12 months? And if you feel like morphing that to, will it make a difference to my patients or whatever, go for your life. But that's the broad question. Will it make a difference to your practice as a clinician or service provider? Now, Damien, how do I do this so that it actually gives me the Alt tab to the, there it is. Oh, look at that. Great. Full screen, thank you, my friend. Okay. 38% think what? Maybe I should have been clearer on the polling. What do the 1, 2, 3, 4 mean?
How much of a positive impact?
Oh, positive impact, got it, right. Okay, so that makes sense. So we think it's going to, we've still got a few more votes coming in. We've got clinicians thinking, some thinking not going to make much difference at all. A little bit of positivity, some thinking it's going to be reasonably positive there. Bipolar. We're suffering bipolarity. Would you agree that that's what we've been suffering for years in the health sector? I think we've got a bipolar result there. Okay, well we might move on then to the second poll, and what do I do there? It switches on to that. Now this is from developers and system providers. So the software folk in the room, the developers, is it going to make a big difference? One person says no, not at all. Fair enough, let's wait for a few more votes to come in here. Big difference. Just let it settle down. Okay. Still settling down a little bit. Oh, are we going to get bipolarity here as well, are we? Okay. That's interesting, isn't it? So we're seeing probably a bit more positivity from the developers of the systems and software. That's probably not totally surprising, but we think it's going to make a tremendous difference out there. We're saying 4 or 5. We're getting uniform positivity still coming through. Is it settling down? Any last votes? Everybody managing to log in? L088. Okay, substantial difference. All right, we've got one more poll, and this one is for everyone else really, which is government, systems operators. You're allowed to vote as well if you've got your phone. You are allowed to. Go for your life. And Rupert, you're allowed to as well, mate. We'll just let that one settle down. Okay. I don't know where this one's going to end up. It's like it's like the worm, isn't it? Where's this one going to turn up? This is looking not as... Okay, 23. We're getting enough numbers to get a result here. These are quite good numbers of people vote. Okay, I think...
Channeling Anthony Green.
What do we say? What would you say on that one? Neville, would you say that's it's a definite maybe. That is just that's ranging everywhere from no, nothing at all, through to yes, very good. But wow, that is a whole spectrum. So clinicians are definitely bipolar, software developers and so on. Yep, it's going to be a good thing. And everybody else is saying, well, I don't know, anywhere from nothing to, yep, absolutely fantastic. As probably, well, let me ask you then the first question, if I may direct that to Rupert. Was any of that unsurprising to you in the light of your experience of the last month, Rupert?
Not really.
Yeah.
No. I think that's pretty much spot on. It's quite representative of what the general community would think. Obviously, if you asked people who are currently experiencing the health system and some of the challenges that they face in sharing information and talking about their problems,
yes,
it would be quite different.
Yes. So I think what we might do now, Damien, is flick to the questions. I'm assuming that's able to. And have we got any votes going? Yes, we've got a couple there. So there's a question that's been bumped up to the top from the look of it there. So what type of organisations can apply for secondary use of data? Great question, because there's been a lot of disinformation around that and fake information about insurance companies and others. I would imagine, Rupert, you're best placed to give us a definitive answer on who can get access to the secondary data.
So the Department of Health are responsible for the secondary use of data policies and not the Digital Health Agency. And so they are best placed to answer all of those questions, but under the current arrangements, I think Neville, it's the Australian Institute of Health and Welfare that will be determining through managing what they currently do around access to data, how that works. But it's certainly a question for the Department of Health as the owner of that policy.
The Act is also very specific. You just come to it and you can just go straight to it. There's some very clear cases which are probably similar to what most governments have in place, and then the legislative review that's happening that, as Rupert said, the Department of Health is looking at. Really, they've been asked to have another look at it, but you will find the Act is probably quite similar to the stuff around other uses and the second uses framework we have to have, and I suspect it'll land in a place where all the other ones land, where there's lots of protections around it. Tony, Tanya, did you want to add to that? Because Tanya's been dealing with a lot of the questions from Victoria, which are the most important ones.
Yeah, good.
In terms of secondary use...
Tanya, can you hold the mic closer? It's really quiet back here.
Sure, is that better?
Thanks, John.
In terms of secondary use, there's been a lot of questions from particularly clinicians around access to research data and how they may access that data. That's to be determined. There are a lot of questions coming back from the Department of Health around how that will work in practice. And particularly for consumers, we also need to do a lot of education around what that means for them, because it's one thing to say I'd like a My Health record, it's a different thing to actually ask whether they want to participate in clinical trials and things like that. So there's been a lot of discussion, but we're still waiting to see what the policy actually looks like in practice.
One thing I will add, when I was in the acting position in the digital health group, that was at the period of time when the department went out for consultation on the usage of secondary data, and Victoria put in a very strong submission about there needed to be absolute control on the part of the individual for enabling the usage of that, and I'm very pleased to see that being taken up.
And that's now been built into the records.
Yeah, that's great. All right, well, we've got some other questions percolating through. Feel free to drop them through, and we will take a couple from the audience as well. But this one is popping right to the top. What should consumers do in relation to their providers who are slow to participate in the My Health record? And there are a number of those, aren't there, Andrew? Thank you very much for that one. Michael Bennett was just telling me about his GP who sort of said, oh, I don't know anything about it, and so on. So what should we do? Who would like to have a crack at that one? Tony, you've got the microphone.
Yeah, and I'll talk. So I just recently went to my GP. I had to go to New South Wales, come back, and be vocal is all I can say. So the medical practitioners have got different views from what I can see. So talking to people in the room. If you truly believe in it, I think you should have a voice, because I've got elderly parents, as probably a lot of us do, and I've gone through the same situation where my medical information is not available. A mistake was just made, just 2 months ago. I'm getting diagnosis, so I believe in it. Go to your GPs, talk about it. They've all got an opinion. The GP that I went to in Melbourne just said, no, I don't believe in it. What's it going to do? Da da da. And I gave him my scenario, and he goes, oh, there's probably some value in that. So they don't realise our situation. So I think you need to tell them your story.
Yeah, absolutely. Anybody else like to comment on that?
That's loud. I would actually completely agree. I think there's that us as consumers, not just because we're in the digital health space, but as people who care about having access to your own information, we have a really important role to play as an advocate, as an educator, awareness raising. And if that doesn't work, opt out of your GP practice and go somewhere else.
Yeah, exactly.
Well, I can actually tell you I had to go not to my regular GP, but to a GP in town. And that GP, I could tell because I was looking at the medical director screen, was connected to My Health record. She said, where did you last have your, for a skin check? And she said, oh, I noticed you've had something taken off your back. I'd like to know more about that. When did you have that done? And I actually had a mobile app on my phone, and I could actually access my own record. And I said, well, here's the information about it. It was MDS data, but it said this is what it was. This is when it was done. This is who did it. And she said to me, that's fantastic. How do you get that information? And I said, see that button there? If you click it, you'll get the same information. And she said, that is fantastic. I haven't been told about this. And so she was a locum working in a city practice. They had My Health record posters up on the wall. She had no idea what it was, but absolutely loved the idea as soon as she heard about it, and couldn't believe that we could also see the same thing.
On the other side of it, the story I'll share is I've been to a GP in the last 2 weeks with a bug, and when I went there, the medical practitioner involved said, oh, I see you've only got a very basic My Health record. You must have set that up back in the early days, which is true. It was when I was actually working with Nita. And he said, would you like us to upload a summary health record, and perhaps we can put on your immunisation data as well, because I'm going to, when did you last have tetanus? And he upsold me into tetanus and typhoid, whooping cough, and even though I was really crook at the time, he said, oh, that's all right, you can take that, and you banged that right in, and anyway, that all went up on my record, and I was very nicely upsold, and there it was, the data was up, so that was helpful. There's a limit to upselling, I can tell you. Absolutely. All right, we've got some others coming through.
Can I have one
Yes, Andrew. That's your question.
I actually found the challenge was not with the GPs but with the hospitals.
Ah.
So when I said providers, so the GPs are not reluctant, and the pharmacists are definitely not reluctant. In fact, if you help them even before the expansion program, they got with the program. But the challenge is the hospitals.
Maybe I could pass to Tanya on this one, I would think. Yeah, so Tanya's been dealing very heavily with the hospitals in Victoria.
Andrew, I completely agree. It's been tough. Particularly with the areas that you would expect would get the most benefits, for example, emergency. They're obviously the most busy in the hospital, depending on which side of the clinical spectrum you sit. You might disagree with that statement. But again, they also have little to no interest in this at the moment. But I do believe it's because there's not enough data in there. As soon as we get more data in there, you will get more adoption. And with radiology and pathology availability coming in Victoria very soon, we should be seeing more and more people take it up because I see the usefulness of it.
Thanks very much on that one. Now, I'm not sure whether we can scroll these questions up or not, Damien. Thanks very much, that's great. Perfect. So, how's the government responded to public concerns regarding information security, privacy and access, e.g. by insurance companies, government agencies? I know Mukesh has been very vocal in early days. We've had everybody else giving their opinion on security, privacy and so on. How has the government responded? Neville.
Just at a high level, can you hear me, John? Good. I think there were, as you know, probably unfairly, there was a lot of palaver within the first couple of weeks of opt-out. My sense is most secretaries and ministers were still very supportive, and that's the message that they gave. They also, I guess, had to respond to public concerns. Are we sure we've covered off this? Have we covered off that? And sometimes you have to sort of overstate that a little bit. But from my sense, most secretaries and most ministers said, we support my health record, we support the opt-out process, and then just went into, I guess, a little bit of concern around the detail, which is where we are. That's my own view. Other folk might have another view.
I think there was a lot of confusion initially between security and privacy and access, and I'd like to hear a view back on around that too.
Just to add to Neil's comment, is when this first started coming out in the paper, we actually ran around every health service in Victoria to say, do you have any questions? Do you have any concerns? Basically, what we got back from the health services was we haven't had one question. Not one question that's come through the media. We have been handing out all our information as they've come through the door, and that's been sufficient. It seemed to be at a higher level around the security access than it was at that patient level, and it seemed to be that it was a very small cohort of patients.
One of the problems I had initially was the wording. I know that's been changed on the site now, but the initial thing talked about security when it was meaning privacy controls, and there was a lot of confusion there. Maybe Rupert, we can pass to you now for a...
Yeah, that's right. So what the agency has done over the last couple of months to start to address some of the concerns that have been raised is to do exactly what you said. There's the discussions around security, and I think the earlier presentation around Singapore and what's been going on there is the heart of security around data breaches. And then there's the whole issue around privacy and patient control, and that's a really, really important one. So we absolutely welcome the public discourse at the moment through the Senate inquiry and everything that is going on, because that eventually just leads to, I think, more confidence in the system, that every avenue has been explored. And from an agency perspective, the other couple of things that we have absolutely been doing is refuting some of the false information that's been put out there. So, for example, I think in the early days of the opt-out couple of weeks, there was all of this information going around that the Immigration Department and the Tax Office can access that information, which is absolutely incorrect. You only need to read the My Health Record Act to know that. So we've spent a lot of time busting myths. We've also spent a lot of time ensuring that consumers understand how to set controls, access controls, what it means, all the different ways that they can manage the privacy of their information, even to asking their provider not to upload a particular event if they don't feel comfortable with that.
Yeah. There is another aspect I'd just add and pass to Tony too. that I think there was a mistaken impression that people can modify their own, whatever clinicians put up, that it's modified, this notion of patient control or personal control, that they could change what's put up there, and of course that's not something you can do. You can change what you put in, but you can't change what a clinician puts in.
Yeah, I think we also have to recognise that we're moving into a world where, one, this information is in our hospitals and in our GP systems anyway, and we're moving into, no matter where we go about it, so you'll see medical directors start to put into the cloud. So it's going to be centralised no matter how you go about it. Our hospitals are looking at that. And we have to do that because that's just the right way to manage yourself in the future. So the reason I'm saying that is, well, our systems currently are easier to access, much easier in fact, than it would be for My Health Record. There's a lot of scrutiny happening with My Health Record, so they've put amazing controls on there. Of course, everything is in one place. So that's got the, if somebody does get the information, it's what happens with Singapore. But we're moving into that space, and we just have to recognise that currently our systems are easy to get into. They're much easier than they will be in My Health Record. Sure, it's harder to trail through it and go through each individual system, but we're going to put our systems up in the cloud. It's going to happen, and we have to control it. The reality is it can be controlled and it can be monitored, and all those kind of things can be put in place.
It was interesting when my record, the information got uploaded, I got a text message immediately through saying your clinician at this practice has now accessed your record and so on. It was, I personally found that very reassuring. I'm going to move on now to the next question. I might just explain this one first, because for the non-techies in this room, there's a word in there around atomic data. And for those who don't know, this is about breaking data down to field level, to actual items that can be uploaded to the record, rather than just, if you like, as a blob or a PDF that can be uploaded, and probably get two answers on this one. But Tony, I think you've got the mic first. The question is, are there any plans to update My Health Record to allow for atomic data in the future?
So it's a multi-tiered system, so anyone that's gone into the technical detail of it, it initially allows either a document to be loaded, so you can't really intercept the data, or you can go right down to the lowest level. And in fact, Victoria's got the good news story on that. We have just started loading fully atomic discharge summaries with medication, SNOMED, A&T. So, and what the agency has done is actually enabled a lot of the major vendors to be able to do that. So as we've started, a whole bunch of other states will start doing the same thing. So the atomic data is being switched on slowly, obviously much more powerful and useful.
Could you just comment, sorry, on why it's more useful?
So secondary use is one of the parts of it, but what it also does is clarify the content. So for example, if you're seeing discharge summary with medications and with procedures and diagnoses, they will be much more accurate than potentially some text. So you'll see the text as well, but you'll get additional information. So it's always an additive thing. Then if you're looking to do a reconciliation, say for medications, because that's an option in the future, you could be taking it down into, say, a clinical system, reconciling that information, and this is future casting. So you can actually use the data as you're going through the system to do some operational aspects as well. Potentially you could do clinical decision support in the future, all those kind of things.
Yeah. Rupert, did you want to add anything further?
Yeah, I just wanted to add that, as Tony said, the My Health Record system is capable of accepting atomic data today. It's actually just restricted by the systems that feed it. So we're seeing a lot of hospitals, not in Victoria, uploading PDF documents because that's the only thing that their hospital's capable of generating. So you can only do so much with that. So I just thought it was worth clarifying as well. It's often seen as a limitation of the My Health Record, but the My Health Record's only as good as the system's feeding it as well.
Yeah, that's a really great point. Thanks for clarifying that. And while you've got the talking stick, the next question is, what is the latest situation regarding allowing consumer-entered data to the My Health record? So my own allergies or whatever else I want to put up there, when can we do that?
So you can do that now. So there's a consumer-entered notes section and a consumer-entered data section, which is clearly marked as such, and you can do that now.
And can clinicians modify the information that you enter?
No.
Okay, it's just yours and that's it. And can they see that information?
Yes, if you allow them to.
If you allow them to, but they probably won't take much notice of it being clinicians there. Oh, sorry, I didn't mean to offend anyone. And there's a question, I'll come to that in just one second.
On that, do they have to? So if I'm as a consumer typing in...
Mike.
Thanks, John. My question follow-up was, do they have to? So if I'm a consumer busy typing in information about my dad and what's going on, because I know he's not telling the doctor the truth, and I can't get to the appointments with him, is there any obligation? Hello, could someone wave at the... is there any obligation on the clinician to see that? Because I know that's a concern of clinicians as well. Thanks, Rupert.
Look, I don't know what the best practice guidelines are for that, but to the best of my knowledge, no, they're not compelled to look in consumer-entered notes. No.
Let there be light. I think we're getting half lights. We're a bit bipolar here. We've got the audience in the line at the front. There we go. IBM, let there be light. We have light. Now, this is a little bit tricky, I'm sorry for audience, because we've only got the one mic, but there was a lady there, I think, who wanted to ask a question, which we might just perhaps quickly pass the mic down to, if we could.
So the question was, can you...
could you just give your name and where you're from?
Kelly, ACHSM. With consumers, can they upload discharge summaries themselves from hospitals? Because there's such a slow reaction in Victoria.
Thank you. Thanks, Val.
Simple answer, no. No. That must come from a registered HPIO, in other words, a registered healthcare provider. Discharge summary.
Now, I think you've answered the next question to a degree, but just read through it.
Tony was just...
Sorry, Tony.
So we're saying a lot of positive things about My Health Record. I just want to talk about some of the challenges as well. So you just highlighted a challenge. Why isn't Victoria as well established as could be? A lot of that's got to do with the fact that we are, the other states actually tend to have a more centralised system, so they'll switch on as a state. So the benefit of Victoria is we're innovative, but we are. The negative of that is we have to go to every hospital individually and switch it on. And while the hospitals are, it's all about funding. I mean, obviously, if we're not funding and enabling that, it's very difficult. So we get a certain amount of funding. There is never enough to do this. And, we all want it to happen, but there's always a limit to what we can do, and that's just normal business. You got to be able to put in the right amount of funding and go to Treasury and look for funding and all that kind of thing. So it's never perfect when it comes to that.
Just looking in Rupert's pockets to see.
Did you bring it in today?
So Tony, if us as consumers started actually requesting our hospitals to get on board with that, do you think that could change the funding arrangements?
Oh,
Is that a Neville question?
Of course it will. I mean, it's all about managing the political system. So you got to make noise at the hospitals. The hospitals will then have a voice. They'll go to the department, your local representatives. You have to go through all those channels and do that. And the consumers were very vocal when it came to the privacy elements. And look what happened. There was a lot of kickback, and they managed to change the system for their own needs. So the consumer is key in this. And if they make enough noise, yes, things will happen.
So secondary use of data, are there different levels of secondary use of data that can be controlled by the user, or is it going to be all or nothing? That's probably a question, I know it's a department question, but maybe...
It's a department question, but from a systems perspective, it's yes or no at this stage, in terms of the way you control it.
I know Victoria put forward the perspective that it should be more fine-grained, but I don't think that's currently been built in.
Not right now, but
yeah,
that could change depending on the policy settings.
Yes.
And one of the risks is you spend a lot of time and energy making it fine-grained, and 98% of the people are yes or no.
Okay. I'm just a fine-grained Nazi. I prefer.
Yeah, very fine-grained, Paul.
All right. Now, Mads would like her 92-year-old dad to be sorted out. He's very sceptical. Following the discussion about Singapore's promotion and training for adoption, what is planned for Australia? And look, that probably falls, Australia, maybe we just talk about Victoria.
Probably Tanya
first.
and Rupert, respectively.
So at the moment, the department is looking out for awareness for clinicians. That's basically what we've been tasked with, and the primary health networks are looking at consumers and pharmacies, GPs, all of that sort of stuff. So we're working in partnership with basically the Australian Digital Health Agency, ourselves and PHNs to get right across the state with this. Realistically, we're not going to get to everyone. It's awareness, and it realistically will probably get to 98% of the population, and the other 2% will probably hear all the negative stuff in the press and they're not that interested anyway. In terms of older Australians, we've actually done a lot of work with Seniors Victoria, as well as the area in the department which looks after seniors and older Australians. The biggest problem that they have is that they can't work MyGov. That's one of the biggest problems. Yeah, is that MyGov actually befuddles everyone and they give up. We are doing a separate project out at Peninsula, and one of the user case stories is somebody needed to change their MyGov account. They went down with them. A person from Peninsula went down to Centrelink with them. They sat there for 3.5 hours. They could not work it out at the end. They said, oh, by the way, why don't you just ring? They rang and they said it's easier to delete it and start again. So I think for a certain amount of the population, the actual front door is basically going to slam shut in the first instance.
That's, now, we don't have anybody from the Department of Health federally here, but Rupert, if you don't mind speaking from a system perspective.
Yeah, from the agency perspective, certainly in this opt-out period, where our education and awareness arm, through the clinical unit, are running hundreds and hundreds of sessions right across the country for consumers, aimed at consumers in conjunction with PHNs and all sorts of groups, Probus clubs, you name it, aged care, associations, to try and reach as many people as we can about the opt-out message, but also about the benefit and the value for them. But as Tanya said, we'll have ended up doing thousands by the time we get through to December, but that probably hasn't reached absolutely everyone in terms of benefit story and how-to story.
I have to say I personally agree with that MyGov front door not being the friendliest of front doors, but all right, now the next question, this is an optional question for panel members because of what it is, which is, have any of the panel opted out, and if so, and if you're willing to share, why? So that's only if you're willing to. Louise.
My partner told me that he was thinking about opting out, and our relationship is in trouble.
I haven't opted out, but I kind of wish I was a bit sicker so I could put more things in my health record.
From my point of view, the benefits just of this far outweigh the negatives. So I'll never opt out. I believe in it too much. Our system is too broken, and I know some clinicians don't like it, and that's fine. Everyone's got a voice in this, but I hear too much of the opposite. That we are fragmented, we're not getting data across, and we make lots and lots of mistakes. So I could never do that.
I might just add that when I was working at NETA before it became the agency, and I was working on one of the infrastructure components, I think 2/3 of the team had said they would never sign up to have a record, and I was absolutely shocked by that. But that was honestly the view. And indeed, you're right. I don't think any of them are there anymore. I think you're quite right. Totally.
How many people have opted out? Just for interest. We've got a couple.
How many have opted in?
So now, genuine. Okay, so many have opted in, and I'm one of those. Don't want to put anybody on the spot here, so I don't need to. But anybody who's opted out, are they willing to share why they've opted out without being on the spot?
I think a big part of it for me was the first point that was raised by the first speaker, which was trust in the government to do the right thing with the data.
Yeah. And look, one of the survey results I saw about government, trust in government, is that it is at an all-time low in Australia. And the last 10 years have been obviously proving that. By the way, that survey came out before the most recent shenanigans. So we are in a pretty disastrous epoch, I think, in terms of government trust, and that has to be playing out.
I just think trust with... I'd just like to clarify, it's not the agency, it's more around things like the Centrelink breach.
Yes, yeah, I understand. You're talking generally. Yes, I understand that.
And I just think trust in general for, information and good corporate citizenship is at an all-time low. Seeing what's happening with banks and other things. So I think
that's true too.
And Cambridge Analytica and all sorts of stuff. And I think consumers are much more aware of the amount of data that people hold about them and what they can do with that data.
To a degree, although I'm still shocked at the amount of people who trusted, at least until recently, banks, insurance companies, Facebook and whoever else with their most intimate details, but wouldn't trust government. I think, well, God, you must be joking.
So has anyone just recently seen that there's a bill going through the government to be able to see all our encrypted data? Has anyone seen that?
Yeah.
So that worries me a little bit. So the government can, make a change at some point where they do things like that, and you go, wow, I can't write a letter anymore, and it could be read by anyone. So that kind of stuff worries me a little bit.
Yeah, I don't write those sort of letters.
Neither do I.
Tom, sorry, Tony. I buy you a drink later.
Hi, Tom Corbin from IBM. I look after the healthcare consulting business for IBM. Actually, I started in that role 7 years ago and left and have just recently come back in to the role. But I remember the early days of PCHR, and I was just going to say, people probably don't remember, one of the early surveys before they launched PCHR, they asked consumers 2 questions, and it was very interesting. The first question was, do you trust the government to manage all your healthcare data on your behalf? And the vast majority of people said no, and that was one of the key reasons why they decided to go with opt-in rather than opt-out. But the more interesting part was, when they asked the question, if you're in an emergency department unconscious and an emergency doctor needed your personal health information to provide care and save your life, would you want them to have access to the data? And the answer wasn't yes. The answer was, don't they have that already? And so realistically, if we're honest about it as Australians, we don't trust the government, but we still expect the government to make sure that the clinician has access to our data. And I don't think we've still resolved that bipolar personality traits that Australians have, where we want both. We want the government not to have access to our data, but we want to make sure
we want
goodies.
Exactly right. I think that's a great point, Tom. Now, I'm aware we're going to keep things to time. We're going to finish at 7:30 and then to have more networking and drinks opportunity. So let's keep driving it forward. These questions are coming through really well. Annette is asking, how does the state health authorities feel the opt-out will drive benefit for their state-based service delivery? How will you get
I'll just start off on that. If doctors and nurses in our hospitals and in primary care can see what happened to you in a private hospital across the border, what meds you were last on, the fact you had an x-ray, what the report was, it can only be good for patient care. It is likely to lead to better care and therefore better outcomes. And we are premising a lot of our work on the fact that that information, some of it will come from Victorian investments and some will come from my health record.
Thanks, Dan.
you'll definitely get a reduction in adverse events. It will go down. There's obviously challenges in the process as well.
But the frequent flyers, there's going to be a huge benefit from those very complex chronic conditions, aren't there?
Even just the small benefit in somebody not having to sit in a doctor's surgery or in a hospital waiting for test results to come back. I don't know how many times I've sat in a doctor and watched her phone up for my test results. And that takes 10 minutes. She talks to me for 5 minutes and the appointment's now over. So to actually drive that service, you actually need to know what kind of pills you're on, what kind of tests you have. And once they get all that information, they'll give you better service.
Well, I can't wait for the medication systems that can tell you about adverse events. My father was hospitalised from a medication adverse event, lost his independent living, and that was the end of the story, really. And it was just a very simple thing. I can't wait for that kind of thing just to be made available personally.
So, and just to add, state authorities know that you need more information than what's in my health record as well. So it's personally controlled. So that means people can choose to take data out, and it's a thinner layer than what we would implement if we were doing continuity of care across the system. We know that we want more, we're going to put something in Victoria, and a lot of the other states have looked at that. But what it does is address that wider view, even though some data won't be in there, let's face it, people will opt out, and leaner data within it, but it will then help the whole ecosystem. So we can control our public hospitals and get really rich data, and the Act allows us to do that, and that probably sort of answers a bit of your comment. As a state government, yes, we can share data. We're allowed to. Why haven't we done it yet? It's wrong. It is wrong. From a federal point of view, it's harder when you're trying to do it right across the system.
Just to go back to the question, the government, so we are premising our work on the fact that my health record exists and will have most Australians in it, and that we actually are signed on to that, and we're using that as assumptions for planning.
Right, yeah. Thanks, Neville. So, Mads is asking, so if the GPs are on board, there was one from, that's been bumped up, okay, got it. So if the GPs are on board, what about the specialists? How are you going to bring them on board? For complex patients, a big chunk of care is provided by specialists, and I know for sure a lot of specialists use bespoke, homegrown systems, their son-in-law wrote, or someone else. How do we deal with specialists, and who's going to answer that one?
I won't. I've got a lot of thoughts on that. I was in Traralgon, which I believe is in Gippsland, and there was a nice bunch of folk, and this was just a little micro thing that came bottom up, by the way. Some GPs and 2 cardiologists there, and they just decided the way they were going to work was to use my health record to share stuff because it was better than all the other stuff. So I guess, there are pockets where people realise in a local area it's actually the best way of doing things. But I'll let Rupert talk to the specialists.
Yeah, I was just going to add to that, Neville, that in terms of the strategy that the agency has right now around provider awareness, it really is targeting specialists in hospital settings. So we're doing a lot of work with private hospitals and obviously through the public hospital system. So I think most specialists touch my health record when they're in a hospital that's connected to my health record, to tell you the truth. We've also got a strategy to look at what we do about specialists in private practice or when they go back to private practice, but that is definitely more challenging. Part of the problem is that a lot of them just don't have CIS systems that provide the sort of data that you need like GPs do. So that in itself is one of the big challenges.
What do the clinicians think about this? So Jeff, what's your view?
I think a lot of the care is actually provided by specialists outside the hospital.
Say that again, Jeff.
A lot of the care is provided outside the hospital. It's not in the hospital. We're very hospital focused, unfortunately, and I don't think that's correct. I think we've got to be very careful about saying that, I think. But yeah, we need to bring the specialists on board, and that's really challenging because they don't necessarily have the right systems, but some do have the right systems, and I think we target those, and eventually others will move on board as time goes by. But you won't get the whole lot, of course, but you can start with some and do it. And that's where I would definitely work, because they are very important.
Thanks very much for that. So
I'll just opportunistically grab the mic.
No.
One of the use cases is, so specialists don't go to work and log on at one place. So you might have 2 sets of rooms and 2 hospitals. So when you started talking about handheld, I think that's when it'll start getting exciting for the cardiologist who's got 4 different places of work. Once we get some stuff up, I think that might be one of the use cases they will really like.
One of the big private hospital chains that have connected to My Health Record also offer a mobile app, and they've connected that mobile app through their infrastructure to My Health Record. So when those specialists look at the app to see their patient list for the day and which hospitals they need to go to, which operating theatres they've got, if they keep scrolling down on that patient record, they'll then start to see anything that exists about them from the My Health Record. So that's one way of getting information to specialists that we haven't designed, that a private hospital group is designed to actually try and push that information in front of them.
At a previous HISA event, I know we had Andrew Howard was making a comment about needing to be the human integrator for his health information and providing that through. So, and I know one of the weak links in that whole chain was through the specialist system, so it'd be great to get that addressed. The next question we've got there is, would the fear associated with the My Health Record being created be reduced if it was made clear that only minimal information will be loaded, initially sourced from Medicare? It's a question from Michael Bennett. So initially, I know it was just loaded up from Medicare, but that may or may not have been made clear. But
I have a crack. Fact of is useful. So I worked in ED for a long time. So MBS says fact of, you saw Dr. X on such and such a date, or you had a colonoscopy. So fact of is much more useful than not knowing anything, and not as useful as the findings of the colonoscopy. I think if we go down the path of saying we're not going to put much in it, it's a tough argument, to be honest.
Fair enough.
I think that question might be getting to the point of that the My Health Record doesn't suck information out of all sorts of systems and create an Uber database.
Yeah.
And I think that has been a common misconception among some consumers, and there was a fear that it was an aggregator of all that information rather than key summary points. I'm not sure though. That was.
Did you want to clarify anything further?
So many people I speak to assume that the Uber record is created like magic. And if they knew, if they looked at, I showed them mine, that it's only PBS data about pharmaceuticals, it's your Medicare visits recently, and it's your immunisations and any allergies. If that was it, well, that exists already. So this gives you the right, I understand, then to share with others.
That's right.
But we don't make that clear enough, I think.
Yeah.
Thank you.
Good point. Next one we've got is that's been voted up. Yes, we need more data. What is the ADHA plan for encouraging the private health system to connect and contribute data?
Yep.
That's
you, I think.
Yeah, absolutely. I think so.
So we're working very hard with all of the private hospital groups, the Australian Private Hospital Association, to connect as many of the private hospitals as possible. I know we've just spoken about private specialists, and absolutely there is a gap there. But I think it goes broader than just private hospitals. I think that question is about allied health, everyone. Is that right? Whoever asked that question?
That one was anonymous, but...
So certainly in the private hospital space, we're seeing great traction there. For private hospitals now, there's a majority of private hospitals connected to My Health Record. They can view My Health Record and can send up a separation summary or a nursing discharge summary, whatever it is they produce. But there is a way to go with specialists, private specialists.
Excellent. Oh, sorry, Tony.
Just to remind briefly, by the way, they're almost about to load private pathology, 80% of the country. A bit more challenging with diagnostics, so private, I think they're targeting 30% or something by the end of this year. I've probably got close to that figure, the right figure there. So there's a lot of work going on in that space as well, and that helps enable a lot of the system for us. So the connection between that for the hospitals, GP specialists is good as well.
Now the next question we've got is somewhat dear to my heart because I do the heartbeat monitoring and stuff with Fitbit, and I have been looking at that for about 3 years now, including when I most recently had the bug. How would you handle data from a private company like Fitbit or Apple Watch for continuous heartbeat monitoring? You've got several million people potentially wanting to upload this kind of information. Will the system be expandable enough to allow that, and should we allow it?
And is it, Jeff, is it any use at all for someone to load up 3 years' worth of Fitbit?
So certainly that's come through strongly in the Australian National Digital Health Strategy, that consumer groups particularly were asking for things like that. But I think that goes to the heart of the question: is it actually clinically useful? Will my health record look at being able to incorporate that sort of data? Absolutely. We'll look at all those sorts of things as part of roadmap planning, but it doesn't do it right now. And a lot more discussions to have before those sort of things happen.
Thanks. So, was that on that question?
Yeah, that was my question.
That's your question? We might just get the mic out to you just for a bit of, we'll come back to this. If we could just pass that down. Thanks.
Yeah, I do want that data.
Yes, I wanted to.
I work at Florey, I'm in research. We differentiate between expensive, very valuable data like MRI scans and cheap and cheerful data that can be collected over a long period of time. It might not seem important, but when you add it to the other data, it is actually.
But that's for research.
Mike's
That's for research.
Yeah, well, I'm hoping that this data is eventually going to end up in our hands.
Now we need the mic back. Sorry, guys. Sorry, just pass it over to Andrew if you want to. Just over to Andrew, and then we'll get.
I'm just going to say that maybe 3 years worth of heartbeat data isn't, but I think there's ample evidence. There's ample evidence that a range of vital sign data, whether it's weight or whatever, if it's properly monitored, has a clinical benefit. So there's truckloads of research showing that if key elements are monitored, that there absolutely is a clinical benefit. And I can see why consumers want to be able to upload anything from blood sugars to weight, temperature for oncology patients on chemo, that sort of thing.
Yeah. Thanks, Andrew. I'm aware of time, guys, so we are going to wrap very shortly, but I'll just get the panel to continue to respond to that one.
We've run some groups very recently with some clinicians to talk about information sharing. And one of the big themes that came through it was that they're very concerned about their data overload, is that actually putting too much in too many systems will mean that they have to trawl through so much information to get to what they want, because really, when they look at it, all they really want is the bits they don't know. So we've got to try and balance the difference between putting 3 years of data up, which would be great for research, versus treating somebody in a clinical setting straight away to make sure that that information that they need is front and centre as quickly and easily accessible as they can get it.
You could probably do both, just display certain elements.
I think Farhana wanted to just add very quickly to that.
No, I just wanted to add one quick thing, is that we've done some work with real-time data, and we did a project where we looked at glucose monitors and insulin pumps for type 1 diabetes, and we monitored a bunch of patients that were doing that in real time, and then we use analytics, and now we can predict 3 hours in advance if they're hypoglycemic. So I think it's not all the real-time data, it's the analytics and the ability to use, and then go back to the patient and say, here's a tool you can now use that's helpful, versus just collecting data. So I think analytics plays a big role in that, which I'm sure is part of your roadmap. Yeah.
Thanks very much. And Louise, I cut you off before. Did you want to say any final thing on that?
Yeah, I know. I'm just thinking, well, you guys sort of covered my point. I mean, the user experience is critical here, and we can't design systems that look like they run off an access database and expect them to be useful. And of course, clinicians just get overloaded with data. But capturing that information, I couldn't agree with you more how important that stuff is. But we need excellent dashboards, great user experience, and it's not that hard because, like, I just got an iPhone X and I just worked out how to take a screenshot. But you know, the point is, like, it didn't come with a user manual. I still can't work out how to turn it off. But you know, there's a bunch of stuff that I can just work out how to do with my phone, and it's not that challenging. And also, aside from self-deprecating humour, is the other important point here is that companies. It's good that the questioner asked about Apple, because Apple have actually already created their own version of a summary health record app, and it's available in multiple hospitals in the United States. And it is just a matter of time before that gets here. And you know, given even all the privacy concerns and all that sort of stuff, consumers are going to be walking into their doctor's offices and hospitals and private clinics and going, oh, here's all my stuff from Apple and I expect it. So, you know, we need to get in front of this stuff and make sure we have really good user experiences.
So I'm going to jump 2 questions on that and then we'll close. I'll come back to the other one.
That's what, like, the notion of Louise turning her phone off. I think that's really scary.
But I can't imagine you ever needing to turn it off, Louise, so you'll never need that button. But the question here is about Apple's personal health app and the My Health record. Will it interface with it? So I think that touches directly to that point. No, I think this is for Rupert.
Oh, look, I don't know, but it certainly would be absolutely on the roadmap. All those sorts of things would be considered, but have nothing more to add right now.
On the roadmap, on the design roadmap there. I think we'll just get a very quick response back from the agency on this one, please, to that question from Michael. How can I decide which mobile app to trust? Because I'm in that position right now. I've loaded up a couple of the different ones. Are they all fine, all trusted, or is what decision-making process should we use?
The apps that connect to it go through a conformance process, so all of them need to do that.
Okay.
So by rights, you know, if they're in the store and they're available and they connect directly to My Health record, then you should be able to have a level of trust in them.
And I know from my usage of it that none of the data is stored on your phone. It is an access point and a display mechanism only.
And I think this is going into a whole discussion around mobile. And there's mobile apps and there are mobile apps, and these are view-only mobile apps that do not take data from the record and store it elsewhere.
Absolutely.
We're not doing that right now. We're not allowing that to happen.
Now, I committed to everyone we will keep to time. We have kept to time. We're just going to conclude at this point now. I hope you agree that that's been a stimulating discussion. I hope you found the Slido system working well for this evening. Would you please join me then in thanking our panellists for contributing their time this evening. Thank you very much. Now, before we break for final network and drinks, I'd like to just do a couple of things. The first is I would like to thank the HISA Vic Council, my colleagues, Damien Clayton-Platt and Tony Abernante, and we've got Mark Moroli and some others, and Charlene, who worked very hard on getting this event together for this evening. So I'd like to thank my colleagues very much for their contribution. I'd like to personally thank IBM for their hosting us in these premises tonight, which is just great, and putting on the networking drinks and refreshments, so thank you to that. So with that said, David, I'll hand over to you to just conclude the evening, and then we'll go to drinks. No problem. Thank you.
Thanks, Bill. Well, what a great evening. Well, what an engaging set of conversations that we've had tonight. Some great questions from the audience and some great insights from the panellists. Thank you everyone for coming along tonight. Just to sort of recap on some of the key messages that we've heard tonight, you know, cybersecurity and trust in the system is going to be paramount going forward with the My Health record, and it's certainly something, you know, looking at the lessons from Singapore, it's something that we can take those lessons and really apply it to our situation here in Australia, and the way to do it is perhaps, I don't know if you've sort of looked at this backdrop here,
Maybe a few of you might think that, as I did, well, is that a woodwind instrument or an organ or something? This here is Q, and Q is IBM's quantum computer. And the reason that this is important is because this sort of capability is going to be able to help deal with the sort of the big data problems and the individual sort of needs that the My Health record will be applicable to the Australian community. And happily, our federal government's got access to this sort of technology. And right here in Melbourne, we have our IBM research capability that's doing research into how do we leverage these sorts of technologies to the benefit of the Australian public. Certainly population health and patient engagement are two other areas which are really, really important. We can learn lessons from other countries. We've heard what they're doing in the US, and to be able to really tailor and deal with each individual in the public will be very, very important. Rupert, it's been great hearing your insights, and Neville, thank you so much for coming in tonight. We're investing a lot in health across the world, and we're certainly serious. IBM's certainly serious about participating and supporting the movements in the health industry. HISA, what a great organisation. I've only just started to learn about HISA. Paul, you've done a wonderful job, and thank you so much for helping to organise it. And in closing, I'd like to thank everyone once again for coming along tonight, and hope you enjoy the networking, and call that a wrap. Thanks for your time.